Hey, how's it going, class? So this is going to be our week 4 lecture. We are going to cover mood disorders. This is our second mood disorders unit. Let's go ahead and get right into it. This is the section where we go over mania and bipolar disorder. So we're going to go over the symptoms, the etiology, the epidemiology, and intervention. All right, so let's get started by talking about the symptoms. All right, so mania is going to be characterized by a distinct period of persistently elevated, expansive, or irritable mood. Elevated mood as euphoria, being euphoric. So this is where somebody has an exaggerated feeling of physical or emotional well-being, as opposed to like depressed mood. So depressed mood is dysphoric, but elevated mood is euphoric. Dystopia, utopia, dysphoric, euphoric. That's how you're going to remember that. So expansive means like high energy, being unaffected by the environment. So this is somebody who's always on the go, no matter what happens. They're always on that high level. Being irritable, we all know what that is, irritation. So I'm familiar with that. So during this period of elevated or expansive mood, you're going to need 4 additional symptoms if you just have irritable mood. Elevated, expansive mood, you need 3 additional symptoms. If you just have irritable mood, you're going to need 4 additional symptoms. So these symptoms must be present to a degree where it is noticeable and significantly different from normal behavior. So these symptoms take the form of inflated self-esteem or grandiosity. So this is someone being, feeling like they're better than others, feeling like they're invincible, being overly self-confident to the point that other people start to take notice. So you have like decreased need for sleep. So this is somebody who is feeling rested after only 3 hours of sleep. Typically, individuals need anywhere from 6 to 8 hours of sleep. Some have more, some have less. If you normally sleep 6 hours a night, and then all of a sudden you start sleeping 3 hours a night, that could be an indication of mania. An individual in a manic episode might be more talkative than usual, or have like this pressure to keep talking. This is going to be referred to as pressured speech. People talking to this individual might have a hard time trying to get a word in edgewise. And also there might be so many words as individuals trying to say that they kind of like all jumble together at once and they just like flow out. So this is going to be someone who's just talking very fast, whole lot of speech, doesn't really make a lot of sense. Flight of ideas or a subjective experience of having your thoughts racing. It's a little bit different from the pressure to speak. Someone with racing thoughts doesn't necessarily have to have pressured speech. For racing thoughts, this is going to be the subjective experience of having like a flight of ideas, thinking about things at 1,000,000 miles an hour. Distractibility, attention being, moved from one thing to the next, just like, you're thinking about this and you're thinking about that. An individual might experience heightened motivation. This could be an increase in goal-directed activity. This could happen at work, at school, socially, sexually. This could also include psychomotor agitation, moving around a lot, making a lot of, meaningless motions. An individual could also experience impulsivity. So this could be involvement in activities that have a high potential for painful consequences. So this kind of risky behavior could be things from engaging in very strange business ventures, like opening an ant hotel. You could have somebody going on buying sprees. Maybe they're a student, but you just saw they bought a $5,000 TV and they took out a student loan for it. There's someone with sexual indiscretions. So this is like having a lot of unprotected sex or a change in sexual behavior. So these are all things known as impulsivity that can be associated with a manic episode. So next up, we're going to watch a video with Mary. We saw Mary before when she was in the middle of a depressive episode, and now this is going to be Mary in the middle of a manic episode. So we'll play a little bit of the video, and the rest will be posted on Compass.
Well, Mary, I'm glad you could come back. Can you say how you're feeling this morning?
Oh, on top of the world.
Okay.
Woo, 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 on top of the world.
What are your plans for today?
Oh, it's just going to be one great day.
What are you going to do?
Well, go out, whatever my doctor says I can do, I should say that right now.
Tell me a little bit about that. You mean you may have some restrictions?
Yeah, still.
Uh-huh.
I went off with my husband last night. I beat him up.
What? Now, tell me about that.
I wanted him out of there.
He came to visit?
Yeah, he came to visit me.
Okay.
And he pissed me off, so I wanted him out of there, so I beat him up.
Now, what do you mean you beat him up?
I forcibly beat him up.
You hit him?
Quite a few times. Oh, yeah, slugging it out.
You were saying something earlier about Jesus Christ and the CIA.
Okay, I'm in incognito for the Lord, God Almighty, Jesus Christ. Okay, I'm working for Him. I have
Okay.
been for years.
Now, what do you mean incognito?
I'm a spy.
And what's your mission?
My mission is to fight for the American way.
Can you say more about it?
The Statue of Liberty.
Okay. But I mean, can you talk more about the kinds of things that you have to do or have been doing as part of that mission?
Oh, I can bring up the wind. I can bring the rain. I can bring the sunshine. I can do lots of things through Christ who strengthens me.
Okay. I mean, you can actually cause the wind to come up?
Oh, yes.
Could you do that today if you wanted
Sure. Oh, yeah.
to? And what gives you the power to do that?
God.
On our walk down, you were mentioning about the air and the smells, and we saw some flowers. You like the outdoors?
I love the outdoors. It's my favorite place to be is outdoors.
Yeah.
Well, see, when I first met my husband, can I just talk?
Sure, please.
When I first met my husband, we lived underneath a bridge and down at a boat dock. We weren't married.
Mm-hmm.
But I believe we got married in the eyes of God down at this boat dock.
Mm-hmm.
Because he popped my cherry, and I had been married before.
When we first sat down, we asked if you could take your gum out, and you had some strong feelings about that.
I've chewed it since I was a little bitty kid.
Mm-hmm.
Don't hurt my teeth or nothing. I got strong teeth, and I like hard gum.
Mm-hmm.
I like to blow bubbles with it.
Okay. Is that a good piece?
Yeah, it's a real good piece.
Okay.
Want a piece?
No, thanks. So,
So we're going to have another video here with John. So John is a little bit different from Mary, but he's also in the middle of a manic episode. So let's go ahead and watch this video. Keep an eye out for some of those symptoms we were talking about before.
Hello there, Mr. Riley.
Hello, you alright? Yeah.
My name's Dr. Betty,
Right.
and I'm the
Right. I'll come and
psychiatrist.
see you because my GP sent me to see you, didn't
Yeah,
he? She said,
yeah.
come and see a trick psychiatrist because then you'll be alright.
Come and see her.
Trick psychiatrist, yeah.
Oh, right,
You must know
okay.
that one, yeah. He said, come and
Yeah.
see you because you have time to listen to me.
Yeah.
He's not had time to listen to me, you see, because
Okay.
he's a GP, he's a
Right.
doctor, but I don't think he's very clever.
Can I just
He's
ta-
not very clever because he's not.
Okay.
Get into this, you see. He won't let me
Right.
talk
okay.
about this.
Well,
He talks this at some time, but then
Yeah.
sometimes he doesn't.
can I just
Sometimes he
clarify why you're here and why I'm here? I'm the psychiatrist
come
in the
and see you.
emergency clinic today,
Right,
and
okay.
your GP's asked me to see
Right,
you.
so that's why I'm here.
Is that right?
That's why yeah, because I've got to tell you about this.
Okay.
Yeah,
Okay.
and this, because there's important stuff in there. Really,
Right.
really
Well,
important stuff.
before
in
we
there.
start with
Come
that,
and see
can I
you.
just ask you what would you
Yeah,
like me
yeah.
to call you, Mr.
What
Riley?
names?
Yeah.
Names are games, so I don't bother with names. That's just
Right.
stupid.
Okay.
Call me John.
John.
Yeah, okay,
John.
what's your name?
Okay, I'm Dr. Betty.
No,
John.
your proper name.
My name is
No,
Dr.
your proper name. Your proper name's not Doctor.
At work, I am Dr. Betty.
You're not. You're Doctor. Doctor who?
John.
Doctor who? Diddly dang, waddly dang. It's good, that, isn't it? Do you watch that? It's fantastic. That program.
Okay.
Now, what
John,
is? Yeah.
can I
no.
ask you how old are you, John?
Oh, no, only as old as the woman you feel, aren't you? Eh?
Right. Okay.
You know, weight the man's heart is to his stomach.
Uh-huh.
Oh, yeah,
So
fantastic.
how old would that make
Food
you,
for
John?
the soul. Nice bit of soul, yeah.
Right.
Eh? No, a bit of fish. I'm half hungry. You got
Right.
any food? Any food round here? Oi, down there, you got any food? I'm starving now.
They won't be able to get you any food.
No,
Shall we perhaps? I'll tell you what.
Okay,
let's perhaps think about
let's
food
get back to
in
this.
a minute.
Let's
Yes,
get,
yes, that's a good
This
idea.
is important. This
yeah.
is why I'm meant to
okay.
talk to you about this.
Okay.
Tell you what's going on.
Tell me a bit about this then.
Well, this is the work I've been doing. You know,
Right.
this is really important, and it's my cure for cancer.
Okay.
That's what it is. You know, it's all written down here.
Right.
Well, it's not written down. It's here, and it's at home in my books.
Right there, we saw Mary, we saw John. They both display different symptoms. I hope that you were taking some notes, thinking about it, what kind of symptoms they were displaying. So let's take a look right here at this review question. So Mary and John have some similar symptoms of mania, although they are presented differently. Mary mentions special powers, talking about how she has the ability to control the weather, and John believes he has found the cure for cancer. So some might say that both experiences are manifestations of which symptom of mania. So is it going to be A, pressured speech, B, elevated mood, C, impulsivity, D, grandiosity, or E, impressionable ideas? A, B, C, D, E. All right, go ahead and pause. There we go. Here's the answer for you. All right, grandiosity. Remember, grandiosity, feeling like you're better than other people or that you have special powers. That's grandiosity. Some of these other symptoms, both of them did demonstrate pressured speech, elevated mood, impulsivity, but none of that is contained within this question. So this question is asking you specifically about these symptoms and what this means. So keep in mind, that was not just something that was present during the video, But specifically for this question, what is this question asking you? And of course, E, we know what E is. That's gobbledygook. I just threw that in there. All right, so now we're going to talk more about bipolar 1. So there are two bipolar disorders, bipolar 1, bipolar 2. Now for bipolar 1, this is going to be characterized by at least one manic episode based on the symptoms that we described. So we often do see major depressive episodes in bipolar 1, but major depressive episodes are not necessary for diagnosis. Now, when we're looking at the list of symptoms for a manic episode, we want to make sure that these symptoms are causing social or occupational distress, impairment, or even requiring hospitalization. So these symptoms are going to be pretty severe, and they're going to cause a lot of problems in an individual's life. So it's not just like, oh, I woke up in the morning today and I feel really jazzed up. This is where all of a sudden I have this extreme change in behavior and it's causing problems in my life. So just like we talked about in the previous slides, when we were looking at the symptoms, a manic episode is going to be characterized by a period of persistent elevated and expansive mood or irritable mood. This must last for at least 1 week in order to be considered a manic episode. In addition to the persistent elevated or expansive mood, you're going to need 3 additional symptoms. If you just have the irritable mood, you need 4 additional symptoms. So when we think about mania, remember you're thinking about things like this euphoric mood, this extreme impulsivity, these racing thoughts, days without sleep is very extreme. Often mania involves impairment that can leave somebody financially devastated, particularly if you're like engaging like massive buying sprees or exhibiting like this kind of goal-directed behavior where like you're going around trying to start a business in a few days or maxing out your credit cards to buy a bunch of things. These symptoms, you have the grandiosity, the decreased need for sleep, the increased talkativeness, you have flight of ideas, racing thoughts, you have distractibility, you have an increase in goal-directed activity, psychomotor agitation, impulsivity. So thinking about a manic episode, you're rising up its elevated mood, you have your manic episode, and then you're coming down. Now this part here, where you're coming down from the manic episode, this is going to be when you have your highest risk for suicidal ideation and suicide attempts. Now remember, when we were talking about depression, we were talking about how that change from either going into a depressive episode or coming out of a depressive episode is the highest risk for suicide and suicidal ideation. Same thing applies with mania. So just reviewing here. So with bipolar 1 disorder, we have at least one manic episode. These symptoms are going to cause social occupational distress or impairment. In order to meet criteria for mania, you need to have persistent, elevated, expansive, or irritable mood for at least 1 week and at least 3 of the other symptoms that we described. If you just have irritable mood, you need 4 additional symptoms. However you look at it, you need a total of 5 symptoms. So remember, we're talking about bipolar 1, we said you need a manic episode to meet criteria. And you could have a major depressive episode, but you didn't necessarily need a major depressive episode. Bipolar 2 requires a hypomanic episode, at least one, and at least one major depressive episode. Now you might be thinking to yourself, well, what is hypomania? Like, how's that different from mania? So look at the word. So you have mania, and then you have hypo. So what does hypo mean? We've heard this before, right? We have like hypo, hyper, right? So hypo means beneath. Hypodermic needle, hypothermia, below. So hypomania is below mania. So this means the kind of distress, the kind of impairment, the severity of the symptoms is going to be less than mania. Bipolar 2 often involves an uncharacteristic change in a person's functioning, but it's typically not severe enough to cause marked impairment in functioning or even require hospitalization. So hypomania is very similar to mania, except in terms of duration. So mania lasts for a week. Well, hypomania needs to last for at least 4 days. But this is going to follow the same number of symptoms as mania. When we think about hypomania, we're just thinking about it as a less severe form of mania. So hypomania involves periods of creativity, increased energy, decreased sleep. As you can imagine, all of these are to a lesser degree than mania. So when we're thinking about hypomania, we are still looking at the same symptoms. We're still looking at the grandiosity, the decreased need for sleep, the increased talkativeness, the racing thoughts, the distractibility, the psychomotor agitation, goal-directed activity, the impulsivity, and the core mood symptoms. Now remember, these core mood symptoms are persistent, elevated, expansive, or irritable mood. Now remember, if you have the elevated expansive mood, you need 3 additional symptoms. If you have the irritable mood, you need 4 additional symptoms. And remember, this is going to be for a period of 4 days. Hypomania is a huge risk for mania. Now, some medications for depression can actually cause a manic episode in people who would otherwise be hypomanic. So this is going to highlight the importance of assessing for hypomania when considering medication. Nice little chart. We're looking at bipolar 1, bipolar 2. Now remember, for bipolar 1, you need at least 1 manic episode. MDE is not necessary. So what is MDE? Major depressive episode. That's not necessary. Can you have a major depressive episode with bipolar 1? Yes. The answer is yes. But it is not necessary. We have the mania must last at least 1 week. That's important. Remember that. So right over here for bipolar 2, you're going to need to have at least 1 hypomanic episode and 1 major depressive episode. So in order to have a bipolar 2, you would need to have a major depressive episode. So that could be at any time. So you could be depressed and then go to hypomania. That's bipolar 2. You could be hypomanic and then become depressed. That's bipolar 2. Period of hypomania must last for at least 4 days. Cyclothymia is going to be another type of bipolar disorder. So the criteria for major depressive episode, the criteria for mania, hypomania is never actually met. But with a cyclothymic disorder, you're going to have more chronic hypomanic and depressive symptoms without ever meeting the threshold for full diagnosis of bipolar 1 or bipolar 2. So for example, when we're looking at cyclothymic disorder, this is going to require these symptoms, these subthreshold symptoms, to last for a period of at least 2 years. So these symptoms must be present for at least half the time during that 2-year period, and these symptoms cannot go away or remit for more than 2 months for this to be considered cyclothymia. These symptoms do cause distress and impairment. So you have somebody who seems depressed, but they're not meeting criteria for a depressive episode. And we have somebody who seems manic or hypomanic, but they don't meet criteria for a manic or hypomanic episode. So remember before, we were talking about how sub-threshold levels of symptoms can still cause significant levels of distress and impairment. So cyclothymia, that's an example of that. So here's a little review here for you. Remember, it's going to be at least 2 years. I have some little words down here. So we have symptoms, SX, TX treatment, DX diagnosis, RX prescription. You might see these coming up later. That's what that means. Symptom, treatment, diagnosis, prescription. Remember that just in case. So remember, you're going to need at least 2 years with numerous periods of hypomanic symptoms and periods of depressed symptoms that are sub-threshold. These symptoms must be present for at least half the time during that 2-year period, and they cannot remit for more than 2 months. These symptoms do cause significant levels of distress and impairment. So now we're going to have some review questions here. All right, so let's look at the first one. So Billy Bob has had 3 manic episodes throughout his lifetime, but has never been depressed. What is his diagnosis? Is it A, bipolar 1, B, bipolar 2, C, cyclothymic disorder, D, schizophrenia, E, chronic mania disorder? It is A, bipolar 1 disorder. He has manic episodes. Mania, bipolar 1. Sandra Sue has had 7 depressive episodes and 2 hypomanic episodes. She also experiences hallucinations and delusions during her mood episodes. Does she have A, bipolar 1, B, bipolar 2, C, cyclothymic disorder, D, unipolar depression, or E, double depression? B, bipolar 2 disorder. How do you know? Well, she has had 7 depressive episodes and 2 hypomanic episodes. Remember, hypomania, bipolar 2. Understand that bipolar 1 is always associated with manic episodes, and bipolar 2 is always associated with hypomanic episodes. Okay? So sometimes people get confused. They said, well, she had 3 hypomanic episodes and 1 manic episode, so obviously she has bipolar 2. That would be wrong. The second you see mania, you are looking at bipolar 1. You could have 47 hypomanic episodes, 89 depressive episodes, and 1 manic episode. And guess what you have? Bipolar 1. So just keep that in mind. So why do they call it bipolar? Well, bi means 2. Polar comes from the word polis, which means end or point. So you have 2 points. Bipolar. So in bipolar disorder, the mood experiences actually vary. So you can often have, long periods of very low mood, but it's not actually necessary for bipolar disorder. You are going to have high periods of energy and euphoria. So you need that hypomania, mania for bipolar disorder. Mood shifts in bipolar disorder tend to occur over the course of weeks or months, not within a day or two. So you need to pay close attention to changes in mood symptoms. This is going to be extremely important for someone with bipolar disorder to prevent relapses in the future. Now, some people might talk about, oh, yeah, he's so bipolar, he'll switch his mood 3 times in a day. That's not bipolar disorder. Remember, these periods of mood for bipolar 1, because remember, bipolar 1 has mania, you need to have that manic episode has to last for 7 days. Not 7 minutes, not 7 hours, 7 days. Then when it comes to hypomania for bipolar 2, that hypomanic episode has to last for at least 4 days. Not 4 minutes, not 4 hours, 4 days. The next time you hear somebody say, wow, they have so many mood swings in a day, they're totally bipolar, that's disparaging the people with bipolar. That's the stigma of mental health. Don't use those terms. And in a related note, we'll talk about more about that with OCD. Little bit of a bonus point to drive home here. You cannot have a unipolar mood disorder at the same time as a bipolar mood disorder. So you will either have a unipolar mood disorder or a bipolar mood disorder. I want you to think about that. Think about that. Just think about that. All right, so here's a graph right here to help you visualize the differences between major depressive disorder and bipolar disorder. So right over here, you're going to see major depressive disorder, right? So major depressive disorder is composed of numerous major depressive episodes. As you can see, none of these episodes remits for more than a 2-month period. So this individual has major depressive disorder. So take a look right there. Okay. Now over here, you're going to see bipolar disorder. So you see we both have major depressive episodes and manic episodes, right? Neither of which remit for more than 2 months. So right over here, you have somebody who has major depressive episodes and manic episodes. So that's going to be bipolar disorder. Here's a bonus question. If someone has major depressive episodes and manic episodes, which bipolar disorder do they have? Bipolar 1 or bipolar 2? Oh yeah, it's bipolar 1, because they have manic episodes. Major depressive disorders consist of major depressive episodes. Each of these lasts for at least 2 weeks, and there's not going to be any manic or hypomanic episodes within a major depressive disorder. For bipolar disorder, this includes manic episodes, and it might include depressive episodes, like in this example, depending on the bipolar disorder. All right, so now we're going to talk about family studies, twin studies, genetic factors when it comes to bipolar disorders. So family studies and twin studies suggest that there's a stronger genetic influence for bipolar disorder than for major depressive disorder. So for example, the concordance rate for monozygotic twins is 0.43. And the concordance rate for dizygotic twins is 0.06. So as you can see with this difference here, just how high the concordance rate is for monozygotic twins, we see that there's some form of genetic influence here. Now, if you have a first-degree relative with bipolar disorder, then you will have a 5 to 12% chance of having bipolar disorder. And you'll also have a 20 to 25% chance of having any mood disorder. Now, children of a parent with bipolar disorder are at a particularly greater risk for developing bipolar disorder. So they're actually going to be at 4 times the risk compared to children of parents without bipolar disorder. So there's going to be a large proportion of genetic overlap between major depressive disorder and schizophrenia. So we see right here there are strong genetic factors. So let's talk about the etiology of bipolar disorder from the biological perspective. So like depression, bipolar disorder is associated with decreased serotonin. However, it is also associated with increased dopamine, which we mentioned before is a neurotransmitter linked to pleasure as well as like reward-seeking behavior. Think of how that maps onto the symptoms. So bipolar disorder is also associated with elevated glutamate, which can cause the overexcitation. There are also differences in areas of the brain, such as the amygdala, which is the brain area associated with emotion, the prefrontal cortex, which is the brain area associated with impulse control, and the basal ganglia, which is the brain area associated with reward. So dysfunctions in these brain areas might lead to an increased risk of bipolar disorder. So there's a lot of different psychosocial factors that play a role in the development of bipolar disorder. So for example, we have stress generation. So similarly to what we talked about with major depressive disorder, stress generation can contribute to the onset or the maintenance of bipolar disorder. So let's look at goal dysregulation. An individual who has a bipolar or is biologically predisposed to bipolar disorder might be more reactive to rewards and successes. So in other words, people with bipolar disorder might be viewed as reward sensitive. And in fact, mania has been found to be more likely after life events involving goal attainment. Now, sleep and sleep schedule disruption have also been implicated in the onset of manic and hypomanic episodes. So specifically think about sleep deprivation. This has been shown to predict mania symptoms. Even things like exposure to bright light can trigger mania symptoms. And disruption of the daily circadian rhythm and social rhythms can also lead to disruption or can lead to the onset of a manic episode. So let's look at circadian rhythm. Who knows what a circadian rhythm is? That's right. It's your sleep-wake cycle. So one important aspect of relapse prevention for individuals with bipolar disorder is to maintain regularity or like a daily routine. So people with bipolar tend to be sensitive to changes in their routine. So your circadian rhythm, which is your 24-hour internal clock, is running in the background, and your brain cycles between sleepiness and alertness at regular intervals. So disruptions in the sleep-wake cycle could cause some problems. So typically the age of onset for bipolar disorder is between 18 and 22 years old. There's not going to be any sex differences between bipolar 1. However, bipolar 2 is more common among females. And this age of onset applies for either the first manic episode or the first depressive episode. Look at bipolar II disorder. The onset for bipolar II disorder is typically a little later, sometimes in the mid-20s. And this illness is most oftenly first diagnosed as a depressive disorder, and then it's not really recognized as being bipolar 2 until a hypomanic episode occurs. Now, when it comes to the length of time between episodes, this varies and can often be very difficult to predict. So the average duration of a manic episode is anywhere from 2 to 3 months, and patients with bipolar II disorder tend to have shorter and less severe episodes. Now, the number of lifetime episodes, this is both for hypomanic and depressive episodes, tends to be higher in bipolar II disorders. Now, 40 to 50% of patients are able to achieve a sustained recovery, but almost all individuals who have one manic episode go on to have at least one other mood episode at some point in their life. And by mood episode, that could be a depressive episode, a hypomanic episode, or another manic episode. Now, there is a 15 times greater risk for completing suicide compared to people without bipolar disorder. Now, past suicide attempts and percent days spent depressed in the year are associated with the greatest risk for completed suicide. So let's talk about some interventions for bipolar disorder. So let's start with medication. So there are a variety of interventions for bipolar disorder. So when looking at medications, one medication that is commonly associated with bipolar disorder is going to be lithium. So this medication right here, the primary function is to stabilize the mood shifts. Now, patients on lithium must be very careful because lithium is actually very toxic in high doses. Now, other medications have also been found to work for patients with bipolar disorder. And this could speak to the similarity in the biology between bipolar and other disorders. So keep in mind that the medication regimen for any disorder requires fine-tuning to find out what works best for the individuals. So unfortunately, between 40 and 60% of patients with bipolar disorder are non-compliant with medication, and this is likely due to side effects caused by the medication. So these side effects are sleepiness, hand tremors, nausea, and loss of interest in sex. Now, the nausea and the loss of interest in sex, these side effects are actually similar to the side effects found in antidepressants. Now, right over here, I have a list of some other medications that are prescribed to individuals with bipolar disorder. This is in addition to lithium, we have antipsychotics, other mood stabilizers, and anti-seizure medications. These have also been found effective for individuals with bipolar disorder. Now, for bipolar disorder, the best plan is usually to combine both psychotherapy and medication. And this is due to the rates of noncompliance with taking your medication and also the severity of the episodes. So doing both psychotherapy and medication, combine those together can lead to the best outcomes. This combination of psychotherapy and medication helps to reduce noncompliance. So it's going to reduce the rate at which patients stop taking their medication. And then also this might lead to patients achieving a more complete remission, like a full remission of their symptoms. This, of course, is compared to taking medication alone. Now, psychotherapy is also going to help clients understand and accept the need for their treatment when it comes to their medication, and also allow them to cope with the impact of this disorder on their lives. Now, when you take medication by itself, it doesn't necessarily allow you to adjust or cope with the impact of the disorder on your life, because rather than you building the skills that you would need to cope with your symptoms, you just get rid of the symptoms with the medication. One of the most popular psychotherapeutic interventions for bipolar disorder is going to be CBT. So that's cognitive behavioral therapy. CBT is going to be very important in helping the individual monitor their mood and restructure their inaccurate thought patterns. So mood monitoring basically involves a process of an individual keeping track of their mood so that they can notice when there are any changes present that might be, indicative of an oncoming episode. So this will allow them to address these feelings early on. When we look at psychoeducation, this is going to be the process of providing information to patients and to their families to help them gain a better understanding of the different components of the illness. So this could actually help families by helping them to identify symptoms of the bipolar disorder. So psychoeducation can be very helpful for families because the symptoms of bipolar disorder can be related to a lot of strain within families. So family-focused therapy is going to try to address these issues and try to work to restore a healthy and supportive home environment, which can be very important for the outcomes of the client. So educating these family members about the disease and how to cope with its symptoms is going to be a major component of the treatment. So working through these problems in the home and providing communication is going to be a big focus of the treatment as well. And this could actually reduce stress in the home. We know that reducing stress can limit episodes. So let's look at IPSRT, which is interpersonal and social rhythm therapy. So IPSRT postulates that stressful life events, disruptions in circadian rhythms, disruptions in personal relationships, and conflicts arising out of difficulty in social adjustment often lead to relapse. So individuals in this kind of treatment are going to work with their clinicians to try to solve interpersonal problems and maintain a daily rhythm. So this daily rhythm includes things like getting to sleep on time, waking up on time, eating on time, and exercising regularly. This kind of rhythm right here can actually increase the quality of life, reduce symptoms, and help to prevent relapse. So the focus is going to be on identifying themes of social stressors and increasing and maintaining the overall regularity in the individual's daily life. DBT is dialectical behavioral therapy. So this is a comprehensive cognitive behavioral treatment that has been found especially effective for those with suicidal or other severely dysfunctional behaviors. The research has shown that DBT is effective in reducing suicidal behavior, psychiatric hospitalization, treatment dropout, substance abuse, anger, and other interpersonal difficulties. One way to think about DBT is as like a supercharged form of CBT. Now, keep in mind that all of these interventions are focused on symptom monitoring and relapse prevention. That is the goal of the interventions for bipolar disorder, is going to be symptom monitoring and relapse prevention. So this is achieved through medication compliance, involving the family in treatment, identifying and reducing triggers, and helping the individual recognize changes to prevent relapse. So let's do a quick little summary here of these treatments. So we have CBT. The goal here is going to be monitoring mood and structuring inaccurate thought patterns. We have psychoeducation. So this is for the family or the individual. We're looking at things like regulating sleep, work, and socialization, identifying and reducing triggers, managing stress, reducing interpersonal conflict, avoiding substance abuse, and also monitoring and preventing relapse. So we have interpersonal and social rhythms therapy. So this is going to be making sure that we don't have any disruptions in circadian rhythms, that we avoid stressful events, and we repair, personal relationships, so that way we can avoid relapse. And then we have DBT, which is going to be especially effective for those with suicidal and other dysfunctional behaviors. And this is actually a supercharged form of CBT. All right, so that's going to be it for week 4, Mood Disorders 2. Go ahead and do your readings. Make sure you do your reading questions. If you have any questions, comments, or concerns, send me an email. Please make sure that you're watching the lectures and you're reading the syllabus. Make sure you do your participation points. If you have any problems at all, go ahead and contact me, wjv3@illinois.edu. All right, I'll see you later.